Medurstand-Understanding Medicine.
Professor Aziz Rehman here, and today we are going to start a new series of lectures on clinical medicine. Now, this lecture is basically designed for those who are going to have or just had their first clinical encounter, typically third-year students, and also postgraduate students when they prepare for their postgraduate examination, and they also, I think, need to revise this. So this is basically introduction to clinical medicine. It would be divided into 3 or 4 portions. So I suggest that you go through all 3 or 4 lectures to get a good idea what actually it is meant by clinical medicine. So, first of all, there are so many sciences, and one big group is medical sciences. And this includes medicine and also many other branches like surgeries and nutrition and prevention, and there's so many branches. But one such science is internal medicine. So this is the internal medicine, the big branch of medicine which deals with almost all internal diseases. Is called internal medicine to differentiate it from skin disorders. But internal medicine has grown so big that it has now divided into many specialties and then subspecialties. And this is not a complete list. Endocrinology, the science which deals with hormones, including diabetes. Diabetology is a branch in itself. Gastroenterology and further branches like hepatology, nephrology, kidney diseases, cardiology, and also including the peripheral vascular disease. Cardiology is actually a very, very big specialty. There are many sub-branches, neurology, and then pulmonology, and this is not a complete list. So what I represent is internal medicine, but I think every internist need to understand his or her limitation, but also I think the specialist also must acknowledge that every patient first should be seen by an internist and then refer to the concerned specialist. I think this is the best way we can serve our patients. So I believe in internal medicine, and that is why I represent Pakistan Society of Internal Medicine, where I happen to be a lifelong member and also senior vice president. So we are going to talk about internal medicine today. Is medicine a science or an art? I think we often have this debate. Some would say it is pure science, others would say it is an art. So let me give you both views and then we try to reach a consensus. Let's examine medicine as a science. Everything we practice these days is evidence-based. That means we just can't prescribe anything which is not based on evidence, and evidence comes from science. Diagnosis of diabetes is based on blood test. Like, we can suspect diabetes, but a formal diagnosis is not possible without a blood test. Tuberculosis is caused by Mycobacterium tuberculosis. This is the name of the organism. How do we know? We learn it from the science. Rabies has 100% mortality. How do we know this? The science told us. Then leukemia can only be diagnosed on bone marrow examination, or maybe it can be suspected from the peripheral examination, but all the details we need to formally diagnose leukemia comes from the bone marrow examination. So this is also science. So I guess I have made a reasonably strong case that medicine is science. Now let's examine the other view also. Science as an art. The practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. This is Sir William Osler, father of medicine. So I think it emphasizes that you need to consider the human part of the science, and that is art. The art of medicine consists of amusing the patient while nature cures the disease. This is Voltaire. So I think I often say that most patients, they get cured during our treatment, not actually due to our treatment, because there are many conditions which are actually self-limiting. So whatever treatment we give, it might give them some symptomatic relief, but actual cure occurs through the natural way. So I think again, if you can keep your patient satisfied by your attitude, by your empathy, and your overall conduct, I think that will help patient cure the natural way. Wherever the art of medicine is loved, there is also a love for humanity. This is Hippocrates. So again, arguing that medicine is art, at least part of it is art. Empathetic attitude of doctor offers half of the healing. This is myself. I'm nobody to make a big statement, but this is what I feel, that if you take the patient empathetically, you try to connect with his or her feeling, and you try to be little concerned and show that by your body language and your words, that will cure the patient, at least half of it. So that is a very strong part in argument in favor the medicine being an art. So what is the consensus? Consensus is that the practice of medicine is an art, but that is based on science. The application of medicine is an art, right? You may know many medical facts, but you cannot apply it on the patient unless you know the art part of the medicine. You need to know how to conduct yourself with a patient who is suffering. Now you have to have an empathetic attitude. You need to listen to the patient and you need to connect with the patient. And all this is, I think, very, very important. And then you need to know your stuff. You need to know the facts. If a patient says chest pain, then you need to know what are the causes of chest pain. So this is the application of medicine as an art, but that art is based on science. So this is the consensus. Now let me dissect two major portions of medicine, that is the theory and the practice. Theory and practice. What is theory? Theory is the facts which you will learn, and I'm going to show you different aspects of theory, and then practice is its application. The two important components of medicine. Without other, no component is complete. Now let's examine the theory part in more detail. Theory is about understanding the disease process. Now, what is the cause? That is called etiology. And what is exactly the mechanism of the disease? What actually went wrong? What happened in the tissues? Like in case of liver disease, was there any inflammation or was there any damage? So that is pathology. So that we need to know. And then the treatment. Whatever the disease patient has, how do we correct that? So this is the theory part. And then the source of this knowledge is like teachers. You can learn from your teachers or your seniors, but you can also learn the theory part from the books, and these days we have a very robust source of information, that is digital media information technology. So all are the sources of information. And then learning sites are classroom or library or just maybe any place, because now you have handheld devices with internet connection, so you can actually have access to the theory part of medicine anywhere and anytime. I am at the other end of the spectrum. You may be just entering medicine. I am on the other end and I'm still learning new facts every day, because medicine is an ever expanding field. Now let's examine the practice part. It is the application of that knowledge and skills for the diagnosis and the treatment. Okay, Now, there are three tools which we need to apply this knowledge in the form of practice. History, for example, history taking is the great tool. History taking means talking to the patient and listening to what he or she says. And this we will have detailed discussion later. Then physical examination. Examination of the patient systematically. First, of course, general physical examination, then different systems are examined. So this is physical examination. Then we have laboratory and imaging. So these three tools are available to us to apply our knowledge to the patient or on the patient to get to the diagnosis and treat him. And what are the sources? I think patients. The best resource for you to learn practice of medicine is patient. So I think you need to be very, very careful handling your patient because they are your teachers basically and your formal teacher from whom you learn. So these are the sources because skills cannot be acquired by reading the facts. Although one source is now on the internet is the YouTube, I think you can learn some skills, surely so, but traditionally they are learned on the bedside. I think even if you learn the basics of these procedures on the digital media, you will still have to learn them on patient because patient is a human and you have to learn how to deal with the patient. And what are the learning sites? The learning sites are wards, the inpatient department where patients are admitted, and OPDs where patients come to have their checkups, and emergencies where patients come as an emergency. So you learn practice in these areas, whereas you can learn theory anywhere. So I think those both have different scopes and different limitations. You definitely need to learn both to be able to practice medicine. So there is actually overlap. You can't say that you have to learn theory first and apply, because if you read just theory, you will be completely lost. You won't know why you're reading and learning all this stuff, all the details, why you're learning unless you know its application. And you cannot apply it, you cannot uh, practice anything unless you know the theory part. So I think the initial years of your medical schooling is purely theory, and later years are mostly the practice, and the inner part, the third year and fourth year, is both theory and practice, because you have lectures in the college and you have then clinical rotation to learn clinical methods and the history taking. So this is, I think, from one spectrum going to the other. Although the theory part never ends, as I said, I just still learning new things, but I think the emphasis becomes less and less because later part it is mostly the practice. Now, clinical medicine is a problem solving game. It's a puzzle game, and because and let me show you the example. Patient comes with a problem, and that problem is usually a symptom. Symptom is what patient describes about his or her condition. If patient says he's got headache, that is a symptom. If patient says he's not sleeping well, that is a symptom. If patient says that there's a pain in the stomach, pain in the abdomen, that is a symptom. So all these things are symptom. Patient basically comes with a symptom and he or she wants the solution, and that solution is a treatment actually. Okay, so problem and solution, what do you think is missing there? Do you think there should be something in the middle? Patient comes with symptoms and expects treatment solution, and we need to offer a solution, the treatment. What is in the middle is the diagnosis. The diagnosis is actually the process of finding out what is responsible for patient symptoms. That is called diagnosis, formally finding out what is the cause of all these symptoms, in terms of a disease. That is called a diagnosis. How we reach the diagnosis, again, there are three tools I earlier mentioned, but here I'm going to mention in more detail, and then we're going to discuss them in subsequent slides. The first is history. History is the information which you get from the patient. So patient would have 1, 2, 3 symptoms, and you will ask all the details about those symptoms, and you will also ask the patient's eating habits, patient's background, patient's past history. Everything comes in the history, and you will actually allow patient to talk his or her heart out. And not only you will allow the patient to describe the problem, you will actually constantly encourage the patient to give you more and more information, because that is required to make a diagnosis, and diagnosis is required to make a to offer the treatment, and you can't function unless you know this skill. And second thing is physical examination. After history, I think in most cases we are reasonably sure what we are dealing with or what is a likely problem. But physical examination, patient expects that his body should be examined, and this again we will discuss in more detail. After physical examination, maybe we should be more sure what is likely to be the diagnosis. And third tool is laboratory tests and imaging. Now, there is general perception in patients that it is the laboratory test or the imaging which confirms the diagnosis. In many situations, they may be right. And this is the concept which many students and young doctors also have. But let me tell you, unless you have gone through this process, this labs and imaging will be no good. So you have to go methodically. History is, I think, of utmost importance. Then is physical examination, and lab test and imaging is of course important, but there is I'm going to discuss the pros and cons of all in the next slide. So lab test should be used judiciously, but we use all three to reach the diagnosis. Okay, so this slide summarizes the fact that patient comes with a problem and wants a solution. We need to figure out the problem, that is called diagnosis, and we need these three tools to reach a diagnosis. So, importance of various sources of information: history, physical examination, and the laboratory test. History first, indispensable. If I say history is indispensable, I don't think you can disagree, because whatever patient is feeling, whatever patient's symptoms are, only he or she can tell. So history is important today and is going to remain important even in future, even if further science develops. Of course, with artificial intelligence, maybe a computer will be taking history, but history will remain important, and it is, in my opinion, indispensable. In some cases, of course, if you see an injured person with broken leg, and you can actually build up the diagnosis without taking history, but of course, in most cases, especially in internal medicine, history remains very important and indispensable. And it is usually free. Of course, if patient comes to you in a private setup, patient will have to pay the consultation fee, and in some big hospitals and in even public sector hospital, there may be nominal fee, but actually there is no additional cost for history taking, no matter how long history you take. And it is very safe. There is no harm, because you don't harm patient. There is nothing that could harm. Of course, in history also, if you're not careful, and with words also you can harm somebody, but in physical terms, history is very safe. And it has got healing effect. Now this is important, and in our culture, people would value those doctors who would listen to patients. So I think if you give a careful listening to patient's history, that will heal half of the problem. So it is very, very important. And in my opinion, in 80% of the cases, you will get the actual diagnosis or main clue to the diagnosis from the history. And physical examination is essential. I use a different word. This is indispensable. This is essential. At least currently it is essential. Maybe in future when we have more advanced imaging techniques, maybe just one test will tell you if there is heart enlargement, if there is liver enlargement, if there are any lymph nodes, if there is any jaundice. But of course, as of today, physical examination is very, very essential. And it is free and it is very safe unless you are very rough in handling the patient. It is very safe, and then it also has healing effect. Many patients, especially patients coming from relatively underprivileged areas, they would feel very happy if you examine them physically. They would actually quote that you were physically examined with stethoscope. So I think a small act of yours is going to have a very, very good impact on the patient. So it's got healing effect. Laboratory, not always essential. In some cases, you can just have the final diagnosis just on history. You don't need to actually have any physical, any laboratory test. So some of them may be expensive. So you have to see if they have good value for money. And some of the tests may be harmful, like biopsies. They could actually harm the patient, and not only they can harm the patient, they can actually, in some cases, they could lead to death also. So you have to be very, very careful when we choose a test. But healing effect, I'm not sure. Some patient might feel relieved after knowing that the laboratory tests are normal. So all three have actually plus side and the downside. History has got the least downside and physical examination in the middle, but I think laboratory tests, you have to be very, very careful in selecting the test, because in different situation, different tests would be relevant. So now let's re-examine the diagnostic process. At the time of a patient's presentation, you take detailed history, and depending upon your level of experience, in many situations you should be able to make a provisional diagnosis. What is a provisional diagnosis? It is the diagnosis which is likely to be true but requires confirmation, right? So that is provisional diagnosis. And then after examination, you should be more sure about your diagnosis. Refinement. For example, if patient gives you history of attacks of wheezing and shortness of breath and cough, and you might suspect asthma, and when you examine the patient, if you find rhonchi all over the chest and patient has got sinuses, then you would be more sure, yes, this is a case of asthma. And then in the third laboratory, you are likely to reach the final diagnosis. Now, this process is actually, not every person has the same, they don't follow the same pattern. Diagnosis may be possible at any level. Sometime after history, you may know what is the problem, and sometime even after the thorough laboratory test, we're not sure what are we dealing with. So this is the actually the interesting part of internal medicine. Every patient comes with a new challenge, and careful history taking and physical examination and judicious use of laboratory will give you the diagnosis. Sometimes diagnosis may not be possible at one visit, but when you follow that patient up, then the disease takes it more typical shape, and then you are able to make a diagnosis, because diseases, they take time to develop the typical shape. And what you read in the book, the book picture, that is not really seen commonly in the real practice. In real practice, you are more likely to see atypical cases. So you need to develop the skill. So in medicine, I always say, yeah, you should be able to make a provisional diagnosis, but you should always keep some room for an alternate diagnosis. And always, you should always be asking yourself what else it could be. For example, if you're sure that this is a case of say for example somebody has anemia, you may be sure that this is simple iron deficiency anemia, but you must always ask, is it is there does it could it be something else? So I think that question should always be asked, could it be something else, or what else it could be. The treatment plan at presentation, patient of course expects some treatment, and this treatment is called symptomatic treatment. And sometime we need to give treatment or some kind of relief treatment even before we start taking history. Now somebody comes with seizures, somebody is brought in with severe dyspnea, somebody comes with severe pain. So I think we need to relieve the pain or dyspnea or control seizure before even we talk to the patient. So sometimes the treatment may be given before the history, but mostly after we take the history, we start with symptomatic treatment. If patient is having vomiting, we can give something to control patient's vomiting. If patient has got diarrhea, maybe we can start giving something to relieve his diarrhea. It may take several days to reach the actual diagnosis, and till then I think we need to give something to relieve patient's symptom, because patient has basically come for the relief. And if the symptoms are not too disturbing and they're mild, for example, somebody's presenting symptom is memory issue, so that is not actually an emergency situation, and there's nothing that we can give patient to relieve his symptoms. So of course we will need to go through the whole process to find out what is the cause of his memory loss and what can be the treatment. So symptomatic treatment at presentation, and we always emphasize that we need to treat symptoms, and the treatment should not actually alter the disease process, because otherwise we will not be able to reach the diagnosis. And after we have made a diagnosis, then we offer definitive treatment. And what is a definitive treatment? Definitive treatment could be referral to a colleague, somebody, some surgeon, or definitive treatment could be a prescription, or definitive treatment could be hospitalization and inpatient treatment, or definitive treatment could be just reassuring the patient that this is something which is not going to give you any harm and there isn't much that we can do about it. Just live your life with it, and it is not going to be a problem at all. So patient comes with a symptom, and we offer a solution in the form of a treatment plan, a definitive treatment plan. And that is what patient came for. So I believe we have done our part, but you need to know how we can reach the diagnosis. This is the first of the series of 3 or 4 lectures. I hope I was able to give you some idea about the clinical medicine, and in next 2 lectures we are going to discuss more details about history taking, physical examination, and laboratory tests. Thank you very much. This is Professor Aziz Rehman from Medurstand. Thank you.